contraception. So pwede pumunta sila sa'yo asking regarding options for family planning. So sa family planning, meron ang WHO na 1, 2, 3 tier, okay? So ano yung 1, 2, 3 tier na yun? Dito sa tier system na to, yung 1, yun yung pinaka-effective, hanggang yung 3, yun yung least effective, okay? So kaya kumbaga, kinlassify niya yung mga family planning methods into the most effective to the ones that are least effective. So isa-isahin natin yung each tier, starting with tier 1. So first in our contraception under tier 1 is your implant or your implanon. Yun yung pinaka-common na brand na narinig natin. So ano pa ba yung ibang kasama sa tier 1? So pag sinabi mong tier 1, it is highly effective such that fewer than 1 pregnancy per 100 women in 1 year ang nabubuntis. Okay? So yung iba pang methods under tier 1 are your IUDs, implants, male and female sterilization. Okay? So i-discuss naman natin ito isa-isa. So yung implant mo or implant, ang kanyang primary hormone is etonogestrel. Etonogestrel is a form of progestin, no? So hanggang kailan mo siya pwedeng gamitin? Hanggang 3 years. So si implanon, kaya siya implant, kasi nilalagay mo siya sa subcutaneous layer mo sa forearm. Okay? So para siyang palito. So kapag papagalaw mo siya sa patient mo, makikita mo, makapalpate mo yan, yung implanon sa kanilang forearm. Okay? So ano maganda about implanon? So implanon has being a progestin has several side effects. So ano yung mga side effects na yun? Also when you appraise the patient, isasama mo siya, pwede ka magkaroon ng headache, acne, pwede ka magkaroon ng intermenstrual bleeding or spotting, and yung pinaka-feared side effect ng mga progestin is decrease of bone mineral density. However, sa etonogestrel implant, hindi yun nakikita, no? Kasi well distributed yung release ng etonogestrel for the next 3 years. Okay? So ang mechanism of action niya is ovulation inhibition and thickening of the cervical mucus. So that's your implanon for you. Ayan. So next tier 1 method is intrauterine device. So we have two kinds of IUD. One is copper, the other is levonorgestrel containing na IUD. So si copper IUD is good for 10 years. So anong mechanism of action niya? It induces local inflammatory reactions sa endometrium such that it will become a hostile environment for the sperm so that fertilization will not occur. Okay? So yun ang mechanism of action ng copper IUD. Now, levonorgestrel containing IUD is another form of intrauterine device. Ang brand name for this is Himelena. Okay? So lang yung alam namin na brand for levonorgestrel containing intrauterine system. So this is good for 5 years. So si copper IUD good for 10 years, Himelena 5 years lang. So ano yung primary effect ng levonorgestrel sa loob ng matres? So it thickens the cervical mucus, it impedes sperm penetration and access to the upper genital tract. So dapat hindi tract. Okay? It also decreases tubal motility and produces a thin inactive endometrium. Okay? So it also causes low levels of circulating steroids, sometimes inhibiting ovulation. So ito yung mechanism of action ng iyong Mirena. Okay, so kailan ka nag-i-insert ng Mirena? So on any day, as long as sure ka na hindi pregnant yung patient. Second, if immediately post-abortion ng patient, pwede ka mag-insert agad ng IUD. Third is immediately postpartum following vaginal or cesarean delivery. Ang caveat lang dito guys, warning lang, mataas yung risk na ma-expel to ng women, diba? Ng women. Kasi diba, naka-open pa yung cervix nila postpartum. So mataas yung expulsion rate nila compared to the other types when you will insert intrauterine device. And fourth is for emergency contraception for up to 4 days following unprotected intercourse. So this is a form of emergency contraception. Kung halimbawa ayaw na maging pregnant and you had an unprotected intercourse for the past 5 days. Okay, so what are your contraindications for IUD insertion? Una sa lahat, pregnancy or even suspicion of pregnancy, acute pelvic inflammatory disease, postpartum endometritis, or infected abortion. So kapag meron kang septic abortion na patient, induced abortion, hindi pwedeng IUD ang form of contraceptive mo sa kanya postpartum. Known or suspected uterine or cervical malignancy for obvious reasons, genital bleeding of unknown origin, and a previously inserted IUD that has not been removed. So obviously that's a contraindication to insertion of another intrauterine device. So these are your other tier 1 methods. For the males, it's vasectomy. So just take note na hindi immediately sterile yung male factor mo, ay yung male partner mo after vasectomy, no? So advise them na ilang pang ejaculation saka talaga completely magiging sterile, rendered sterile yung male. And so for the females naman, it's bilateral tubal ligation versus bilateral salpingectomy. So kailan kami nagsa-salpingectomy? So nagsa-salpingectomy kami guys kapag nag-offer kami sa patients ng opportunistic prophylaxis against ovarian cancer. So why? Because salpingectomy removes possible STIC. Your STIC stands for serous tubal intraepithelial carcinoma, which they say is the precursor for ovarian cancer. Okay? So pag tinanggal namin yung bilateral fallopian tube, lessen yung chance na magkaroon si patient ng ovarian cancer in the future. Okay? So kaya bilateral salpingectomy na yung karamihan ngayon ng mga OBGYN. But otherwise, we still offer bilateral tubal ligation. Yes, yes. So those are your tier 1 methods. So these are the highly effective methods for family planning. So let's move on to tier 2. So ano yung mga under tier 2? Injectables, pills, patch, and ring. So dito sa apat na to, itong injectables and pills, ito lang yung mga mostly ma-encounter nyo in practice. No? So injectable, ang pinaka-common dito sa Philippines is your dipomedroxyprogesterone acetate, 150 mg intramuscularly every 3 months. Okay? So ito yung mga ayaw natin na side effects ni DMPA, irregular bleeding pattern. So bakit? Because it causes thinning of the endometrium. So when your endometrium is thinned out, the atrophy causes parang nagkikis-kis yung endometrium with each other, causing atrophic vaginitis. So yun yung nagkakos ng irregular bleeding pattern in patients given DMPA. Weight changes, so ayaw na ayaw ng patients natin. Headaches, mood changes. So these are just some of the side effects of your DMPA. So ang isa sa mga ayaw natin na side effect is bone loss. Okay? So this is reversible if taken less than 2 years. So as much as possible, we don't extend our use of DMPA beyond 2 years. And when we do give DMPA to our patients, we have to give them calcium supplementation along with the DMPA, okay? To help with this side effect, the decreased bone mineralization or bone mineral density. Okay, so kailan ka pwedeng magbigay ng DMPA? Anytime during the menstrual cycle, as long as the patient is not pregnant. So as what I'm saying guys, when you give contraception to your patient, dapat na-ensure mo na hindi siya buntis at all. So for example, may mga strict na mga OBGYN, before they give DMPA, the patient has to take a pregnancy test first to make sure na hindi siya buntis. So if this is given later than 7 days into the cycle, backup contraception should be used for 7 days. So an example of a backup contraception, pwede silang mag-barrier method in the form of male condom for the next 7 days if the DMPA is given later than day 7 of your cycle. Okay, so next form of contraceptives under tier 2 are your pills. So dalawa lang yan usually guys, progestin-only pills or your POP and your combined oral contraceptive pills. When you say progestin-only, so obviously progestin lang yung component niya. Isa lang yung component form mo. When you say naman COC, combined meaning may combination ka ng estrogen and progestin. Okay, so what it does is it inhibits ovulation. So yung mga progestin-only pills natin, 28 days, 28 tab packs usually yan. So you take that continuously and dapat same time of the day every day. So why? Because yung progestin mo, it has an ovulation inhibition dose and nare-reach niya yung steady ovulation inhibition dose within 48 hours pa. Okay? So ang ginagawa ng progestin is that it suppresses your luteinizing hormone. Remember our menstrual cycle, diba? Yung after ng LH surge mo, when your corpus luteum takes over, tapos may progesterone siya na napoproduce, yun yung parang minimimic ni progestin. Okay? So the progestin inhibits your LH. So, di ba, as I mentioned, important to guys, within 48 hours pa magiging steady yung amount, and magiging steady to ovulation inhibition dose mo ng progestin ulitin. So, important siya when, I discuss later on yung regarding sa missed pill. So, take note of that, 48 hours yun. So, yun siya. So, basically, what it does is it inhibits ovulation by suppressing your luteinizing hormone. Now, your combined oral contraceptive pills, usually the estrogen is in the form of ethinyl estradiol. So, ang kadalasan na composition ng pill pack mo is 21 days. 21 days lang yan na hormonally active plus 7 days na pill-free. Ibig sabihin, when you instruct your patient, 21 days mo siya tuloy-tuloy iinumin, may 7 days na hindi ka iinom ng pills. Okay? Tapos, you will expect na within those 7 days, doon ka reglahin. Alright? So, nag-ovulate ka ba? Nilagay po pala ako eh. So, mag-ovulate ako. Hindi ka nag-ovulate guys. Hindi ka nag-ovulate kapag naka-pills kayo. Alright? So, may iba po bang preparation, doktor? Kasi iba 28 days. Yes, may ibang preparation. Doon sa mga 28 days na yung laman ng pack, it means na 21 doon yung hormonally active. Yung 7 doon are usually just ferrosulfate, okay? So, ito yung kadalasan na available sa market natin. Meron pa tayo ng mga iba-ibang, mga multiphasic na tinatawag, pero I haven't seen in practice anyone using yung mga multiphasic. Ibig sabihin ng multiphasic, iba-iba yung dose mo, depende kung anong part ka na ng pill pack mo umiinom, no? Pero most of the time, isang dose lang yan for all the pills in the pack. So, they all share the same dose. So, next. Yan. So, how do you take it? So, ideally, this is how you should be taking it. You take one pill regularly, preferably at the same time of the day every day, especially if you're taking your progestin-only pills, okay? Kasi it takes time for the progestin to reach the ovulation inhibition dose, okay, to suppress your LH. And then, you usually start within the first 5 days of the menstrual cycle. So, parang kakabayan yung what's supposedly your menstrual cycle for that month. But it may be started anytime, provided that for 7 days, if you start beyond day 7 of your menses, kailangan mo ng mag-backup method, okay? Mag-backup contraception. So, Dr. Laura, what will happen if I miss my pill? Okay. So, kapag 1 day ka pa lang nakamiss ng pills, okay lang. Take the pill ASAP. Okay, no backup required. 2 pills, pwede ka pa rin namang pwede ka rin mag-take ng 1 pill ASAP, okay? Tapos, mag-take ka rin later on, pwede rin, habulin mo yan, sige, go. Basta ikaw walang backup contraception required, yung 1 or 2 pills na miss. Pero kapag naka 3 pills ka na, ito na yung kailangan mo ng backup. Remember kung kailan natin na-reach yung ovulation inhibition dose, it's 48 hours, diba? So, kapag nakalampas ka na doon, most likely hindi pa inhibited yung luteinizing hormone mo at this point. So, pwede kang masilitan dyan ng LH surge mo. So, what you do is you use backup for the next 7 days, okay? And if there is intercourse within the past 5 days, you have to employ or you have to use an emergency contraception. Okay, malinaw? So, again, pag miss pills, kailangan mo ng backup contraception. Okay? Backup contraception, and kapag nakipagtali ka within the past 5 days, you have to take emergency contraception. Ngayon, that is if you miss the pills for the first 2 weeks. Pero pag na-miss mo siya for the 3rd week, you just start a new pack right away. Okay? Para ka na rin, kasi nasa ano ka na yan kumbaga, past day 14 ka na yan, going to day 21. Kung doon ka na lang, mag-new pack ka na lang, para hindi ka malito. Okay? Pag basta doon ka na sa last week, sa 3rd week ka na, mag-new pack na lang instead of using the current pack that you're using. So, maginaw, no? Basta, ang tandaan nyo, pag 3 pills na yung na-miss mo in a row, you have to do backup contraception for the next 7 days and emergency contraception. And kapag nasa 3rd week ka na, start a new pack. Describe now what you're currently using, okay? So, what are your absent contraindications? This is for your combined oral contraceptive pills. So, ang estrogen kasi, it will render you coagulable. So, basically, kung isa-isasin pa natin, o hindi ko na isa-isasin na medyo marami, this is found in blueprints, this table. These are the contraindications to your COC, okay, to your combined oral contraceptive pills, because baseline may mga hypercoagulable na itong mga diseases na to. So, kung magbibigay ka pa ng estrogen, you will render the patient na mas hypercoagulable. So, you will incur morbidity in those cases. So, we don't give COCs in those cases. So, ano mga examples? Thromboembolism, pulmonary embolism. We don't give those to our patients with, we don't give combined oral contraceptive pills to these patients. So, ano pa ba? Ito, endometrial cancer or breast cancer. Usually, these are hormonally responsive tumors, especially your endometrial cancer. So, magbibigay ka pa ba ng more estrogen sa may endometrial cancer na? Okay, so mas natitrigger mo lalo yung endometrial malignancy in this patient. So, no more na, no? Hindi ka na pwedeng magbigay ng COCs in cases with breast or endometrial cancer. So, hindi na natin isa-isahin lahat, but basically, ang pinaka-concern mo is the hypercoagulable component or hypercoagulable factor ng estrogen in your combined oral contraceptive pills. Okay. So, another tier 2 method na admittedly I haven't used for my patients, I don't know anyone who's using this in the Philippines, are your patch and your ring. Okay, so ito si patch, ito si ring. Parehas lang sila na may estrogen and progesterone component. Therefore, ang mechanism of action nila is inhibition of ovulation. Because remember, when I was presenting to you the menstrual cycle, di ba when you have your gonadal hormones, what happens is your gonadotropins are inhibited. May negative feedback sila. Remember, yun yung sa luteal phase, no? Na kung tumaas yung estrogen and progesterone, mababa yung gonadotropins mo or your FSH and LH. So, in effect, it inhibits your ovulation. So, ganun essentially for all the hormone-containing contraception. So, patch and ring, they're the same, no? Because of the estrogen and progesterone na inhibit yung ovulation. So, how do you use this? Parehas sila na 3 weeks on, 3 weeks nakalagay yung patch, or 3 weeks nakalagay yung ring, and then 1 week off. Yung parang rest period, yung parang pill-free period for this form of contraception. Now, hindi na natin masyadong i-discuss yan because we move on to the other tier naman, to the tier 3 method. Okay, so ito yung least effective. So these are your barrier methods. So kasama na dito yung male condom, and then these are your other forms of barrier method, your diaphragm, your cervical cap, and your female condom. Now, I don't want to discuss too much about the barrier methods because these are really not readily available in our country, no? So dito na lang tayo sa next tier 3 method, which is your lactation amenorrhea. Okay, so si LEM, lactation amenorrhea, essentially what it does is that it backs on your prolactin, which inhibits your GnRH. So again, everything else down the cascade of your HPO axis is inhibited or is decreased because of the inhibition high up in the hypothalamus, no? Or sa GnRH level pa lang. So, sino yung pwedeng mag-lactation amenorrhea method? So, those na hindi pa bumabalik ang menses, no? So, ibig sabihin, hindi pa sila nag-ovulate, hindi pa bumabalik yung fertility nila. So, if you're still amenorrheic within 6 months and you're exclusively breastfeeding, you may perform lactation amenorrhea method as a form of contraception. Okay, so these are the other methods, calendar rhythm method. So, anong ibig sabihin nito? So, remember, tinuro ako kayo kung paano mag-compute ng cycle. So, you will look for the longest cycle and the shortest cycle. For the shortest cycle, minus mo ng 18. For the longest cycle, minus mo ng 11. So, yung makukuha mo na difference is yun yung interval na fertile ka. So, doon ka hindi mag-sex, okay? So, for example, 30 minus 18. Ayoko na mag-compute. Okay, sabihin natin 25 minus 18. So, 7. Okay, so 7. Yun yung shortest cycle mo. Tapos, 30 minus 18. 30 yung longest cycle mo. 30 minus 11. So, 9. So, hindi ka pwedeng mag-intercourse between day 7 to 9. Okay, sobrang short naman period mo. So, anyway, that is kunwari lang, parang ganun, example lang. So, standard days method, so instead na magpo-compute ka ng fertile period mo, you just abstain for the next few days, days 8 to 19. Okay? So, again, ang day 1 mo is the first day of menses. So, you abstain, you don't perform sexual intercourse dito sa days na to. So, yun yung standard days method. Okay, so other forms of contraception, ito is mga fertility awareness na method to So, based on body temperature, so refrain from vaginal intercourse from day 1 of menses until 3 days after the temperature rise of 0.2 to 0.5. Okay, so ito yung based on body temperature method. Next is Billings ovulation method or cervical mucus method. Ito naman, you observe the quality of the vaginal discharge. No? In the presence of clear, wet, and slippery mucus, you refrain vaginal intercourse until the 4th day after the peak of wetness. Okay, so yun yung Billings ovulation method. Sexothermal, iko-combine niya yung DDT saka itong Billings. No? So, kailan mag-refrain from sexual intercourse when the woman senses cervical secretion and the third full day after the rise of the basal body temperature. Okay, so bakit ganun, no? Kasi diba around the time na mag-ovulate, umiinit yung temperature mo. So, yun kasi yung basis niya. Yun ang basis ng sexothermal sa kanong DDT. Alright, so sa 2-day method naman, once she notices any secretion, any type, color, or consistency, the couple should refrain from vaginal intercourse on that day and the day after. And finally, saliva ovulation monitoring. So, ito very tedious to guys. The couple should refrain from vaginal intercourse on the days that a burning pattern is observed. So, ano itong burning pattern? Ang burning pattern. So, sa saliva to guys. So, kailangan tingnan yung saliva under a microscope. If you see a burning pattern, then you should refrain from vaginal intercourse. So, ano ang reason behind this? Yung burning pattern is caused by your increase in estrogen. So, sino ulit ang nag-increase and nagpuproduce ng estrogen? It's your follicles, no? So, the moment na sobrang taas na ng estrogen level mo such that enough siya to cause burning pattern sa saliva nung female patient, then ibig sabihin fertile si female patient. Kasi nandun na siya sa point na sobrang taas ng estrogen niya, malapit na mag-LH surge. Enough na yung to cause LH surge. Okay? So, ito yung mga means, no? So, as you can imagine, very tedious siya, no? Kasi kailangan mo pa ng microscope, titingnan mo pa yung laway mo, ganyan. So, very tedious, hindi siya commonly employed na contraceptive method. But for me, it's enough for you to understand na yung burning pattern, this is caused by increase in the estradiol in your patient or estrogen in your patient. Okay? Okay. So other tier 3 methods are your spermicides and coitus interruptus or withdrawal method. Okay, so I don't think I need to explain this too further. Okay, so yun yung 3 tiers nyo. Again, yung tier 1, yung pinaka-effective. Yung last tier or yung tier 3 method, sila yung least effective. So we now move on to your emergency contraception. So madalas tinatawag sa ano. So how do you give your emergency contraceptive? So this is effective if the treatment begins within 72 hours after coitus. Pag na-miss yung 72 hours, pwede nyo pa rin siyang i-take up to 120 hours after intercourse or coitus. So we have contraception. First one is plan A. So you take one dose of rivanorgestrel 1.5 milligrams orally. Or alternatively, pwede ka rin mag-take ng 0.70 12 hours, for 2 doses. So 0.75 now, then after 12 hours, another 0.75 milligram tablet. Okay? So next or pill. So plan B, so ito yung mas commonly ginagamit namin, emergency room. So we give a minimum of 100 micrograms of ethinyl estradiol and 0.5 milligrams of rivanorgestrel. So 4 pills, i-explain ko mamaya kung bakit 4 pills yung pinaprescribe namin in each of 2 doses 12 hours apart. So ang commercially available is yung trust pills. Ito yung, ang preparation niya is ethinyl estradiol plus rivanorgestrel. So ang isang pill kasi ng trust pill mo is 30 micrograms. So times 4, meron kang 120 micrograms. So pasok siya, di ba? So ang rivanorgestrel naman niya is 125 micrograms or 0.125 milligrams. So times 4, pasok ulit siya na nasa 0.5 milligrams rivanorgestrel. Yung magbibigay mo na dose if you give 4 pills of your trust pills now and then after another 12 hours, magbibigay ka ulit ng another dose ng 4 pills. Okay? So ano yung disadvantage itong plan B? Nakakasuka siya guys at masakit siya sa ulo. So alternatively, you can insert copper IUD within 5 days from intercourse. So na-discuss natin to when we were discussing the intrauterine device as a form of contraception kanina, di ba? So these are your options for your emergency contraception. Okay, so let's move on to another chief complaint among your patients, which is increasing abdominal girth. So it goes without saying, kapag sinabi nila na lasing chan, because of the pressure, occasionally these patients also present to you with abdominal pain. Sometimes dumadating sila sa emergency room, tapos sobrang sakit ng chan. Kapag ganon, in the presence of ovarian new growth, ang assessment namin sa kanila is ovarian new growth in complication. Okay, so let's discuss ano ba yung mga possible causes ng increasing abdominal girth among our patients. Okay, so again, I have another index case for you. So this is a 55-year-old G1T1 1001 who was referred for enlarging abdominal girth. She denies weight loss or anorexia, so wala siyang constitutional symptom. And ito yung kanyang transvaginal ultrasound. Okay, there is massive ascites and occupying the abdominal pelvic area is a, 9 by 10 centimeter complex mass. So when you say complex, it's a combination of cystic and solid components that is predominantly solid. So that's a bad sign. Mamaya sasabihin ko kung bakit. Her CA125 or antigen 125, that's a tumor marker, was noted to be 100 units per milliliter. So what is the appropriate surgical management for this? So do you have a diagnosis na in mind? So most likely, since this is a gynae patient, aside from GI pathology, siguro ito na yung next na commonly diagnosed assessment for us, no? So ito yung mga pertinent points sa patient. First of all, she's more on the elderly na siya, no? 55 years old. She has massive ascites. And look at the quality or the description of her mass. It's a 9 by 10 centimeter complex mass. And bad time na, as I told you a while ago, itong pagiging solid niya, no? And look at her CA125. It's elevated at 700 units per milliliter. No? So I don't remember all the exact values of CA125, but definitely this is elevated for her age, no? So likely she's already postmenopausal, and it is greater than 35 units per ml in her age group. This is noted to be elevated. So ano ang appropriate management for this case? Okay, so most likely this is a case of ovarian growth. So paano mo masasabi kung benign or malignant? So these are your clues. So note na, hindi naman porke mas malaki sa 8 centimeters yung mass ay automatic malignant na siya. But more or less, habang lumalaki kasi yung mass, mas tumataas yung risk niya for malignancy. Okay, na-get? I hope that's clarified, no? So in terms of size, mas malaki yung mass, attention, mas mataas yung chance ng malignant. So greater than 8 centimeters, like in the case of our patient, medyo mas worry na tayo ng malignant siya. Especially dun sa HB patient, no? She's already 55 years old. So in terms of consistency or in description ng mass, kapag benign, more of cystic sila, no solid components, or at least kung may solid components, minimal lang yung solid components, no septation. Kapag malignant, solid yung quality ng mass, mixed. Pag sabi ng mix nga, it's a mix of cystic and solid components, multilocular, multicystic, nodular or capillary, irregular walls, and septa. In terms of laterality, most of the time yung mga malignant yung bilateral, pero hindi siya all the time, okay? Kasi pwede pa rin may bilateral ovarian growth. Tapos yung parehas na ovary, pwede naman silang benign masses. So, hindi naman to all the time, okay? So, other features na that will point you to a malignant ovarian growth are ascites, peritoneal masses, because this could be a sign of metastasis to your peritoneum, and lymphadenopathy, okay? So, most of the time, ang spread ng ovarian cancer natin is via the lymphatic drainage. So, if you have lymphadenopathy, especially in your pelvic node and your para-aortic node, then you are suspicious for malignant ovarian growth. Alright, so since ito yung impression ko sa patient, ovarian growth, probably din malignant, ito yung aking plan for the patient. So I will perform total hysterectomy with bilateral salpingo-oophorectomy with staging, okay? And since I am considering a malignant process here, I will refer pre-operatively to a gynecologist na oncologist as well, okay? So refer ka agad, hindi lang intra-op, dapat pre-operatively nagre-refer na tayo agad sa kanila. Alright, so ano ba yung complete surgical staging? So isa-isahin ko sa inyo guys kasi mag-a-assist na kayo ng mga gyne-onco procedure. So it's important for you to learn this kasi hindi lang siya sa ovarian growth, probably malignant gagawin, pati rin sa mga ibang forms of gynecologic malignancy. Okay, so isa-isahin natin. So this is how you perform complete surgical staging. So, systematic abdominal exploration via a midline incision, no? So, para bakit midline? So, we prefer midline para in case mag-extend kami above the umbilicus for better exploration, mas magagawa namin siya is midline incision. Versus kung, halimbawa, panin seal yung incision natin, okay? So, this is what we do, the peritoneal fluid cytology, and this is how you perform it. You do sampling of washing of 4 areas of peritoneal cavity, so sa diaphragm, right and left hemi-abdomen, even if there is tumor rupture or presence of tumor on the external capsule, in clinical, or clinical disease stage 1, okay? So, mag-PPFC ka pa rin kahit may tumor rupture ka na on your assessment, okay? Ayan. So, at sa pelvis, So, bali, apat yung kukuhanan mo ng PFC or peritoneal fluid cytology, diaphragm, right and left hemi-abdomen, and pelvis, okay? So, and then you do careful inspection and palpation of all surfaces. So, kaya siya exploratory laparotomy. You explore your abdominal pelvic organ. So, after which you may biopsy and do resection of any suspicious lesions kung meron man, masses and adhesions. After which you remove the pathologic ovarian growth. So, either right or left. Okay? Sabihin natin, for this patient, sandali natin itong right, okay? So, yung right yung kanya may ovarian growth. Kasi hindi ko note kung right or left. Kasi sometimes hindi namin nakikita talaga yung laterality on imaging na sobrang laki ng mass. So, sabihin na lang natin for this patient, right yung tatanggalin ko. So, we perform that, removal of the pathologic ovarian growth or pathologic adnexa. So, when you say removal of the primary ovarian or fallopian tumor, magkasama na yung ovary saka yung fallopian tube. So, this is unilateral salpingo-oophorectomy. Okay? Then after which you perform total hysterectomy with unilateral salpingo-oophorectomy. So this is if the patient has already completed family size, tapos relatively old yung patient, pwede mo na talagang i-total hysterectomy yung patient. This will change kung halimbawa reproductive age woman, tapos may desire for future pregnancy, tapos yung tumor naman niya is not one with poor prognosis, ganyan, pwede kang USO lang for those patients. But for this patient, since she's postmenopausal already, the completed family size, we tend to perform total hysterectomy with unilateral salpingo-oophorectomy. So pagkasandal mo na nitong right fallopian tube and ovary, you then remove the uterus and the contralateral fallopian tube with ovary. Alright? Okay, so what else do we do in terms of staging? We perform intracolic omentectomy. Okay? So intracolic omentectomy is yung omentum mo sa ilalim nitong transverse colon. However, if you have gross omental involvement, like this patient, kunwari may cancer cells dito or mukhang may suspicious area siya sa omentum mo, you do intragastric omentectomy under the stomach. Yung lahat ng yun, bali parang pakalbuhin mo talaga siya, tatanggalin mo the entire omentum of the patient. Okay? Malinaw? Usually we just perform IO, intracolic omentectomy, but in cases of gross involvement of your omentum, intragastric na siya. So mas malaking portion ng omentum yung i-excise mo. And then, we perform random biopsies of normal peritoneal surfaces. Okay? So 2 samples from each of the following: undersurface of the right hemi-diaphragm, from the bladder reflection, so ito yung bladder mo, okay? From the cul-de-sac, which is behind your uterus, right and left paracolic recesses, so paracolic, so gilid nitong bowels, and then right and left pelvic side walls. Ayan, so yan yung mga, kung marami tayong isi-fix na sample, tapos magkaibang side pa yan, hindi mo pwedeng ipagsama yung right and left, so since naman po sila na right paracolic areas, hindi, hihiwalay mo siya, right sa left, okay? So important yun sa mga gyne-onco later on, pag titingnan nila yung histopathologic report ng patient mo, okay? Okay, so then we proceed to systematic lymphadenectomy. So itong lahat ng guys, technically pwedeng kami lang yung gumawa nito, no, general gyne. Pero kapag kailangan mo nang mag-perform ng BLND or bilateral lymph node dissection, you already refer to your gyne-onco. Okay, so sila yung nag-perform nito. So we perform complete pelvic lymph node dissection and para-aortic lymph node sampling. So ang difference ng dissection sa sampling? Sa dissection, tatanggalin mo talaga lahat ng lymph nodes na makikita mo dun sa border kung saan sila dapat magtanggal. So, ang usual na tinatanggalan nila ng lymph node is your external iliac artery. So, lahat. So, ito yung common iliac, diba? This is the internal, this is the external iliac artery. So, lahat ng lymph nodes dyan, within the anatomic borders na na prescribed by their operative technique, tatanggalin talaga nila kahit hindi siya grossly involved. So, ang sampling naman, from the name itself sampling, hindi mo naman kailangan tanggalin lahat ng para-aortic lymph nodes there. Sometimes they forgo this if, in certain cases, kapag wala namang gross involvement yung lymph nodes, no? Pero most of the time, they get samples from your para-aortic lymph nodes also. So, dito sila kukuha sa area na to. Okay? So, again, kapag mag-fix kayo ng specimen, hiwalay si external iliac lymph node. Sorry, I missed this out. May isa pa silang kinukuha dito over the obturator nerve. Okay? So, mga yung lymph nodes din na mahanap nila dito, they also do lymph node dissection. So, parang balik, pag in terms of lymph node sampling and dissection, meron kang 1, 2, 5 specimens dapat. Kasi right external iliac lymph nodes and right obturator lymph nodes, tapos yung left din, plus yung para-aortic. Okay? So, marami talagang specimens when you do complete staging in your patient. For mucinous tumors or other types of tumors with the appendix grossly involved, we also perform appendectomy. Bakit? Anong ibig sabihin ng mucinous? Ibig sabihin, when you cut your specimen, mucin yung lalabas, parang sipon. Okay? Yun yung quality ng fluid inside your ovarian growth. Why do we do that? Because sometimes they are actually metastatic from a primary appendiceal carcinoma. Okay? So that usually happens. So we also perform appendectomy for cases of mucinous na tumors that are malignant looking intraoperatively. Okay. So now this is your complete staging for the patient. This is the complete procedure. Okay, so if spell out sa iyo ng resident to, this is how you will write it. Okay, exploratory laparotomy, peritoneal fluid cytology, unilateral salpingo-oophorectomy. So sa patient natin kunwari right salpingo-oophorectomy, total hysterectomy with left salpingo-oophorectomy, intracolic omentectomy, bilateral lymph node dissection, para-aortic lymph node sampling. So kung mukha siyang mucinous on cut section, you also perform appendectomy. Okay, I hope that's clear. Alright, we have another case of a patient presenting with encasing abdominal girth. Lumalaki po yung tiyan ko do. Alright, so this is a younger patient. She's an 18-year-old naligavid with encasing abdominal girth with occasional pelvic heaviness. There are no other associated symptoms. So this is her ultrasound picture, no? So there is a 10 by 10 centimeter cystic abdominopelvic mass with echogenic lines and dots. Ayan, so parang may dot, may ito yung dots, tapos may mga lines, and a 1 centimeter and 2 centimeter solid hyperechoic focus. Okay, so maliit lang naman siya na solid area. So ano yung consideration mo for this case? Okay, so at this point, I want to orient you na regarding the different types of ovarian growth or ovarian cancers. So as usual, like any other part of your body, your mass will either be benign or malignant. Okay, so I will discuss both. So these are the general types of your ovarian tumors, alright? So yung pinaka-common is your epithelial. Okay, so the way I remember these types, iniisip ko yung different parts of the ovary kung saan siya pwedeng mag-arise. Okay, so I hope you will appreciate the color coding that I did for this slide. No, so the first type, which is the most common, is your epithelial tumor. Okay, so epithelial, kung papansinin niyo orange din siya, diba? So they arise from the epithelium surrounding your ovary. So the most common types of your epithelial tumors are your serous and your mucinous. Other types are your Brenner tumors, and these are the other lesser known types. Hindi mo lesser known, rarer. Okay, mas rare na types, endometrioid and clear cell. So bakit naka-highlight the endometrioid and clear cell? Because these two types of tumors are associated with your pelvic endometriosis. So if you have a patient na may history of pelvic endometriosis, or yung symptomatology niya, nagre-regla pa lang siya, may cyclic pelvic pain, may dyspareunia, infertile, etc., kung consistent siya with pelvic endometriosis, tapos eventually nagkaroon siya ng ovarian growth, di worry, because she could be having one of these two tumors, no? Endometrioid na adenocarcinoma or clear cell carcinoma. So clear cell, ayaw natin yan because this is a very aggressive form of ovarian cancer. So, si serous mucinous, si Brenner, meron silang benign and malignant counterparts. Si serous and mucinous, diba, sila yung serous cystadenoma, pag cancer, serous cystadenocarcinoma. Okay? So, ano yung pathophysiology behind your epithelial tumors, especially your cancerous type? This is caused by frequent breaks in the epithelium. Okay? So, which is usually caused by frequent ovulation. Okay? So, therefore, if alam mo yun, alam mo na protective against cancer are those that will prevent ovulation. Naget? So, kapag halimbawa, ikaw ay nagbuntis multiple times in your life, that is protective against ovarian cancer. Why? Because habang hindi ka buntis, and during the time na naglalactate ka, if you're doing lactation and method most especially, hindi ka nag-ovulate nun. So, longer yung periods mo na hindi nag-ovulate, longer yung time na hindi na-injure ang iyong epithelium. Okay? So, that's one example. So, if you take your pills, your OCTs, diba, either conjugated pill or your combined oral contraceptive pill, that is also considered protective. Why? Because, diba, ang primary mechanism of action ng iyong pills is to inhibit ovulation. So, lahat ng mga conditions. So, ganun na intindihin yung mga protective factors and risk factors. Intindihin nyo yung main theme ng mga risk factors or ng protective factors. So, bakit siya nagiging protective? Bakit siya nagiging risk factor? Okay? So, in the same light, ano yung mga risk factors mo? So, kapag ikaw ay parating nag-ovulate, so early ka nag-ovulate, early ka nag-start ng menarche, or late ka nag-menopause, diba? So, those are possible risk factors kasi hindi, or pagiging maligabid kasi never kang nagkaroon ng period na hindi ka nag-ovulate. So, yun, parating nag-violate yung epithelium mo, parating siyang nagkaka-injury. So, you are more at risk for having these epithelial tumors of your ovaries. Okay? Nag-get? So, ano yung isa pang pwedeng pagmulan ng ovarian new growth? So, the next common na family of ovarian growths are your germ cell tumors. Germ cell ay galing dito kay gametes, diba? Sa oocyte mo. So yung mga germ cell, when you say germ cell, sila diba yung eventually nag-form ng mga germ cell layers. So what will eventually become the embryo, yun yung pinagmulan ng germ cell tumors. So syempre, saan siya manggagaling? From your oocyte. So ito yung mga tumors under your germ cell tumors. This germinoma, this is the most common malignant germ cell tumor. Yolk sac tumor, choriocarcinoma, your teratoma, and your embryonal carcinoma. Okay? So mamaya, siguro later on sa next ko na lecture, which is on the pathology na integration ng OB topics, I will discuss each one, no? Isa-isa, papakitaan ko kayo ng histology, baka ng gross pictures. But for now, enough na sa akin malaman na alam nyo kung sino yung mga under germ cell tumors and kung ano yung mga corresponding na tumor markers. Okay? Kasi in terms of presentation, in terms of age group, halos magkakaparehas lang yung mga nakikitaan natin ng germ cell tumors. So saan mo usually nakikita si germ cell tumors? Sa young patients. Okay? Kaya mamaya, papakita ko sa inyo yung guidelines namin. Bakit? Nag-order kami ng extra tumor markers for patients with complex mass. Kasi yung ultrasound nila, they present very similarly, no? Complex mass, etc. Except for the teratoma, may ano siya, mamaya papakita ko sa inyo yung isang picture ng ultrasound na distinguishing teratoma from the other germ cell tumors. Okay, so si teratoma, just like the other, just like your epithelial tumors, meron siyang malignant and benign counterpart. So yung benign na teratoma is called mature cystic. So ibig sabihin ng mature cystic teratoma, lahat ng germline na makikita mo sa iyong histology ng teratoma ay mature. Okay? They are well differentiated. Meron naman tayong tinatawag na immature teratoma. Pag immature teratoma, that's considered a malignant tumor. Okay? So ano makikita mo sa immature teratoma? You will see neural tissue. Okay? So yun yung isa sa mga hinahanap mo if you're suspecting immature cystic teratoma. Alright? So, aside from may hindi pa ba tayo na-mention, meron pa diba itong pink, yung mga follicles around. So, at saka itong lighter orange. So, ano yung mga pwedeng mag-arise na tumors from your follicles? Yan, sila yung sex cord tumors. So there are two sex cord tumors common. These are your granulosa cell tumor and your Sertoli leading tumors. So these are both malignant, okay? Si granulosa cell, ang pinuproduce niya is estrogen and inhibin. So si granulosa cell dahil nagproduce siya ng inhibin, ano ang kanya, ng estrogen rather, so doon tayo kay estrogen. Ano ang sa tingin yung symptoms ng merong may granulosa cell tumor? So kapag meron granulosa cell tumor at ikaw ay prepubertal, meaning bata ka, magkakaroon ka ng precocious puberty, okay? So mag-bleed ka, magkakaroon ka ng breast prior to the start of menarche. Okay? That's because of your estrogen. Si Sertoli leading naman, Sertoli will produce your testosterone. So, kung si granulosa cell is precocious puberty, si Sertoli leading naman, this will present with virilizing symptoms. So, ano yung mga examples ng virilizing symptoms? Hirsutism, you can have lowering of your voice, basta they are all masculinizing signs and symptoms. Okay? So, another one pala regarding granulosa cell. So, as I mentioned, precocious puberty kapag meron kang bata na may granulosa cell tumor. Okay? So, alam niyo na ha, kapag meron kang bata na may abdominopelvic mass and one of her presentation is precocious puberty, like she's having clotting, nag-develop siya ng breast, ang iisipin mo, she could be a case of granulosa cell tumor. Okay? Kapag matanda naman, like postmenopausal, ano yung presentation niya? So, ang presentation niya sa matatanda is postmenopausal bleeding. So, ganun pa rin, no? May bleeding factor yung granulosa cell tumor, whether sa bata or sa matanda. Now, finally, this is the last tumor. Hindi pala finally, isa pa pala akong i-emphasize na kind ng tumor that you will see in your ovary. So, ito yung lighter orange. From your stroma naman, you can have your fibroma. So, fibroma, kapag binuksan mo siya on part section, mukha siyang leiomyoma. Okay? Even though ultrasound na pagkakamalan to na subserous myoma. No? So, si fibroma comes from the stroma of your ovary. Okay? So most of the time it's benign, but this is the one benign tumor, your fibroma, that will present with ascites, okay? Because of peritoneal irritation. So later on, I will also feature that sa pathology correlates ng OB. So one other kind of tumor that I want to share with you is your Krukenberg tumor or your metastatic tumor. Most of the time, this is bilateral, okay? Very rarely ka makakita ng metastatic to the ovary na unilateral. So it will present as bilateral na solid mass, and ang history ng patient, meron din siyang history of GIT or gastrointestinal tumor. So kapag nakita mo yun sa patient mo, ang iisipin mo, possibly this is a metastatic tumor, very rare na dalawa yung primary tumors mo, no? So kapag meron kang GIT tumor, like colon PA, tapos nag-present siya with bilateral U-growth, pwedeng yung nakikita na bilateral U-growth ay metastatic from the primary GI tumor. So we call that Krukenberg, okay? Yun yung special name natin for that kind of ovarian U-growth. Alright, now we move on to the tumor marker. So again, at this point, ito lang muna yung mga gusto kong ma-memorize ninyo, okay? So what do we request for? For epithelial tumors, we request for cancer antigen 125. Now, yung mucinous tumors kasi, they don't always present with elevated CA125, so we request another cancer antigen, which is your 19-9. For your dysderminomas, we request for LDH. Your yolk sac tumor, we request for alpha-fetal protein or your ESC. And for choriocarcinoma, of course, because these come from your syncytial trophoblast, we request for beta HCG. Guys, so yung malilito about choriocarcinoma kasi may dalawa din siyang kind. May gestational kind, yun yung mga nasa gestational trophoblastic disease. Meron ding mas rare na non-gestational choriocarcinoma. So yun ay inherently nagpuproduce sila ng beta HCG without having been coming from an H mole, na naging invasive mole, etc. Okay? So last is your granulosa cell tumor, for which we request inhibin, no? So hindi yung estrogen yung pinaka-tumor marker natin kasi di ba very variable siya sa women. No? So yung inhibin yung we-request natin na tumor marker for your granulosa cell tumor. Now, we also request for CEA, especially if we co-manage with other services and if you have a high index of suspicion for GI pathologies. So for your Krukenberg, we request your CEA. Okay? So yan yung isa natin pang request. But usually, itong mga to hanggang dito kay inhibin yung request natin. Okay? So lahat na doktora, left and right, request kami. So lahat pala ng ovarian U-growth orderan ko nilang EST, LDH, beta HCG, etc. Hindi naman lahat. Okay? So ano yung age na kailangan nating mag-request ng tumor marker and ano dapat yung quality or consistency ng ovarian growth mo. So we only request for LDH, AST, beta HCG. This is in our local guidelines if the woman is under age 40 and she presents with a complex ovarian mass. This is because of the high likelihood of germ cell tumors. Now, if she presents with abnormal uterine bleeding, you may also request for inhibin. Okay? Because she may be having granulosa cell tumor. Okay? She may have granulosa cell tumor. Alright? Okay, so let's go back to our patient. So eventually, since malaki yung mass, no, 10 by 10 centimeters, this patient underwent laparoscopic surgery and you performed oophorecystectomy. So again, guys, kindly save the ovary for your young patients as much as possible. If you're not considering malignancy, hopefully oophorecystectomy lang yung gagawin ng gynecologist na makaka-duty nyo. Alright, so on cut section, ito yung nakita nyo, no, unilocular na cystic mass, may hair and sebum within. So what is this case? We are dealing with a case of mature cystic teratoma. So ito yung mga well-differentiated na germ cell tissues. No? You have hair, tissue, sometimes may teeth pa yan. So itong mga siblings na to, yung dot and dash na yan, na very variable yung itsura sa loob ng iyong cyst, yan yung nire-represent no sebum saka ng hair. Okay? So, yan siya. Yun yung corresponding structure niya on gross picture ng ovarian growth. And remember, di ba, I told you meron siyang 2 centimeter na solid nodule. So, hindi naman kami suspicious for malignancy, especially kung ganito yung picture ng cyst, no? Because that is what you call a Rokitansky nodule. Okay? This is a nodule found in your mature cystic teratomas and it represents a focal area of calcification. So, pwede may bone within yan, may teeth dyan, ganyan. So, yan yung Rokitansky nodule na tinatawag. Okay? So, that is seen in your mature cystic teratomas or your dermoid cyst. Alright. Now, let's move on. This is another case of increasing abdominal girth. So, tingnan natin. So, meron na tayong matanda, meron na tayong nasa reproductive age. Now, we'll look at this case. We have a young patient, a pre-pubertal patient, no? Supposedly pre-pubertal. A 5-year-old was brought to your clinic due to intermittent peri-umbilical pain for the past 4 months. She has no headache or blurring of vision, so take note of this. This is a pertinent negative, kumbaga. And upon probing, her mother reported breast enlargement and occasional spotting. So, ma-alert ka na yan. 5 years old lang to, may breast enlargement. Tapos, parang nag-mention siya. On ultrasound, the patient had a 6 by 4 centimeter complex abdominal pelvic mass. Again, when you see complex, it's a combination of solid and cystic components. And now, we are asking which is the most likely diagnosis. So, na-mention ko na to kanina, ang tumor marker for this is inhibin. Most likely, you are dealing with a case of blank. Okay, so anyway, first of all, this patient is presenting to you with precocious puberty. So, when do you investigate for precocious puberty? So, these are the instances when you have to investigate if the patient is less than 6 years old with breast or pubic hair. So, either yan, no? So, either nag-enlarge siya or nag-underenlarge siya. And then, pwede kayong mag-investigate, warranted din, if you have both of the features, pag less than 8 years old. Pag or lang ito, guys, we tend to just observe the patient, okay? Pag or hindi kami nag-investigate. Kailangan dalawang features yung nakikita mo sa patient, both the breast and the pubic hair, if you will investigate at less than 8 years old. However, like in the case of our patient, less than 6 years old siya, breast lang yung present sa kanya, hindi na-mention kung may pubic hair, still, you will investigate for causes of precocious puberty, okay? And another instance when you will investigate for precocious puberty, if you have an increased risk for intracranial pathology, like for example, you have a strong family history or you have a pertinent medical history na nasabihan yung patient na meron siyang intracranial pathology nung baby pa lang siya, and there is rapid pubertal progression, then you will investigate for a cause of your precocious puberty. So, review lang natin kung ano ba dapat normally yung puberty. How does one patient undergo puberty? So, ito yung typical age na makikita mo yung mga developments during puberty. So, meron kaming time, hindi mo call it, hindi siya mnemonic pero one way to memorize yung mga events ng puberty is up, down, up, down. So, ano ibig sabihin ko nun? So, the first event of your puberty is your start, okay? So, that is breast involvement, so up. And then after that, you go down because you will see your pubic hair. There will be pubic hair and kasama na dito yung axillary hair. Essentially, nag-adrenarch na sila, okay? So, this is facilitated by your androgens. So, again, up, down, up yung next because may maximal growth. Height, this is height, okay? Maximal growth in terms of height. Dito sa mga patients, like puberty. So, dito yung growth spurt. And after your growth spurt, you expect your menarche to down. So, linalabas yung blood. Yan. So, that will be the last event seen in your puberty. And that is like your breast that is mediated or facilitated by your estradiol hormone. O, ano ba yung cause mo ng precocious puberty? So, again, babalik tayo sa HPO axis. Diba? Sabi ko sa inyo, very important yung concept na yan because it could either be GnRH dependent or GnRH independent. Kapag sinabi mong GnRH dependent, this is coming from a central cause because saan galing si GnRH? It comes from the start of your HPO axis, which is higher up in the hypothalamus. Okay? So, what are your examples of GnRH dependent na causes of precocious puberty? It could be idiopathic. It could be coming from a CNS lesion. That's why I noted a while ago sa history ng patient, wala siyang blurring of vision, wala siyang any signs na meron siyang increasing intracranial pressure. Okay? Primary hypothyroidism because, as I mentioned, sa mga previous parts ng lecture ko, diba? Hypothyroidism, low FT4 levels will cause inhibition of your GnRH. So, yung cascade mo sa HPO axis will be inhibited as a result. Next is your GnRH independent cause. So, mas peripheral tong cause na to. So, an example is having an ovarian new growth, particularly if it's the granulosa cell tumor type. Okay? Because this is a hormonally active tumor that produces estrogen. So, that will cause the precocious puberty in patients with ovarian new growth. Okay? With granulosa cell tumor. Pwede rin siyang adenocortical tumor or any problem in your adenocortical system because this will increase the production of androgens and your androgens will eventually be converted to your estrogen. So, magpe-precocious puberty sila. Okay, one other cause of your GnRH independent precocious puberty, ito take note of this guys kasi this is a board exam question, no? Your McCune-Albright syndrome. So, ano yung McCune-Albright syndrome? This has a triad. So, ito yung triad ng McCune-Albright. Fibrous dysplasia, Paseo-Olay spot, and precocious puberty. Okay, so ano ba meron sa McCune-Albright syndrome? This is a genetic disorder wherein yung clamp mo or your cyclic adenosine monophosphate is always on. Okay, nasa on mode siya parate. So, in effect, ito yung mga end result niya sa mga batang may McCune-Albright syndrome. So, kapag meron kang patient na nag-present with spotting, precocious puberty, tapos meron siyang frequent fractures, and if you look at his or her skin, meron siyang mga Paseo-Olay spots, ito yung iisipin mo, no? McCune-Albright syndrome. Now, the last cause na ipapresent ko sa inyo under GnRH independent causes of precocious puberty is your iatrogenic causes. So, ano yung sabihin ng iatrogenic? So, pwedeng nabigay ka ng topical estrogen sa patient mo for one reason or another. So, this will cause premature stimulation of your HPO axis. Okay? So, particularly sa dun tayo sa O, no? That part of your HPO axis. So, because of the exogenous estrogen, pwede kang magkaroon ng precocious puberty. Alright? So, malinaw tayo dyan. So, dito sa patient natin, because of all these things, no? So, wala siya nitong pertinent negative to, wala mukhang hindi naman primary CNS lesion yung sa patient natin, and meron siyang signs of precocious puberty, plus in the presence of an abdominal pelvic mass, which is likely ovarian in origin, you could be dealing with a case of granulosa cell tumor. Again, what's our tumor marker for your granulosa cell tumor? It's your inhibin. Ayan. So, in the young, this presents with precocious puberty, and in the old patient, and the older patient, especially your postmenopausal patients, they will present with postmenopausal bleeding. Okay, so just to recap, ito na yung mga nalaman natin, ito na yung mga na-discuss natin na chief complaint/concern ng patient. We'll now move on to the last, nag-cycle end ng timeline. Doon na tayo sa menopausal years or postmenopausal years ng patient. Okay, so under menopause, I'll be discussing two of the common symptoms that the patient will present to you with. Before I discuss with you yung chief complaints nila, doon muna tayo sa physiology behind menopause. So what happens when you're menopause? So first, I'll give you a board exam type question. You have a 49-year-old patient who consulted due to dyspareunia. She had her menses 18 months prior to her consultation, so take note of the time component, 18 months. She also complained of hot flushes and frequent mood swings, which is true regarding her hormonal milieu. Okay? So first of all, kung patient ba na to, menopause na? Most definitely. Okay? So ito tatanong ko sa inyo, ano ang makikita mo sa kanya, kung ipapa-hormonal assay mo siya, ano yung makikita mong picture? Alright, so she's considered menopause because there was already permanent cessation of menstruation for 12 months due to loss of ovarian follicular activity. So remember si patient natin, meron na siyang loss of menses. So loss of menses for the past 18 months. Diba? Yun daw yung last menses niya. On top of that, meron din siyang other symptoms of menopausal patient. So ano ba nangyayari when you're menopause? So when you're menopause already, athletic na yung follicles mo. So when there is athlesia or atrophy of your follicles, you decrease amount of these hormones which are all produced by your follicles, diba? Your estrogen, your inhibin, testosterone, and your AMH, lahat yan bababa. So, because mababa itong mga hormones na to, especially your estrogen and inhibin, what happens is walang nag-negative feedback to your anterior pituitary. Such that, tataas yung SSH mo. So, this is a hallmark of your menopausal transition, no? Kapag mataas na yung SSH mo, mababa yung estrogen and your inhibin. Okay? Okay, so just some terminologies na parang hindi kayo malito. So when you say perimenopause, this refers to the years prior to menopause. So this encompasses the change from normal ovulatory cycles to cessation of menses. So usually yung mga patients na who come to us with irregular menses already, they're already becoming anovulatory, no, because of your decreasing amount of follicles already. So because of this, they either have skip periods or longer intervals, so 40 to 60 days in average, which is the hallmark of this period, no, your perimenopausal period. So this is your menopausal transition. Now, when you see climacteric, this now refers to the period of time when a woman passes from reproductive age to non-reproductive stage. So ano yung in-encompass climacteric? Mas mahabang time period because it includes this one, the perimenopause, the menopause, and the postmenopausal years. So mas mahaba si climacteric, okay? So ano yung mga signs and symptoms? So si patient, diba, this is her complaint. Hot flashes or flashes, they're the same thing. So this is a sudden sensation na naiinitan sila, okay? So pag halimbawa naiinitan yung mga, yung mga matatandaan, they always bring with them their abanico, their fans, or they have their electric fans with them na mini, because this is the hallmark of female climacteric. So bakit nagkakaroon ng hot flashes or flashes? So this is because decrease in estrogen changes the thermoregulation in your hypothalamus. So ito yung response ng katawan to the decrease in estrogen. So these are the other signs and symptoms of your menopausal patient. So kapag they undergo these symptoms, guys, huwag nyo naman na silang lokohin, no? Kasi hindi biyo mag-menopause. Imagine from period na okay yung estrogen levels mo, suddenly i-withdraw yun sa'yo. So ano ba kasi yung point ng estrogen sa katawan ng mga babae? So it promotes good vasculature in the pelvic organ. So in effect, it also causes magandang connective tissues, no? So na-maintain yung collagen. So kapag ikaw ay wala ng estrogen in your body, which happens during your menopausal years or your menopausal transition, you could have dryness, itchiness, burning sensation, which could result to dyspareunia or painful intercourse, no? Kasi yung vagina mo is nawawala na yan ng hugay, hindi na ganun ka well vascularized, tapos yung mga connective tissues mo, nababawasan na rin yan ng quality during the menopausal years, okay? So yung mga patients na yun, nagbibigay kami sa kanila ng vaginal estrogen to help address these symptoms. So they could have vulvovaginal symptoms, pelvic organ prolapse, because why? Nababawasan na yung connective tissue, yung integrity ng connective tissue, therefore yung mga ligaments nila, nag-fail na yan during the menopausal years. So ang effect, nag-pelvic organ prolapse sila. So they can also have sexual dysfunction from this, decline in cognitive function. Ang masama dito, there could be elevation of total cholesterol, and there is also loss of trabecular bone, more than cortical bone, although both to nawawala during the menopausal years or the postmenopausal years. That's why these patients, we usually work them up or we screen them for osteoporosis, diba? Okay. So, regarding this patient, ano ang true regarding her hormonal review? She's already postmenopausal. If it decreased FSH, so we know that this is false. Dapat in case na to kasi wala nang negative feedback sa kanya. In case AMH, in case inhibin. So again, itong dalawang to false. Therefore, ang tama lang is letter B, no? Decreased estrogen. The rest ay mag-decrease din, including your testosterone. So that's what you see in patients who are already postmenopausal. Alright? Okay, so one of the chief complaints na maririnig nyo sa mga patients na postmenopausal, so alam na nga nila, no, hindi na talaga sila dapat mag-bleed. And then, they suddenly arrive at your clinic telling you na nag-spotting sila. So kapag ganun, warranted na investigate natin yung cause ng bleeding nila. So these are your differential diagnosis for postmenopausal bleeding. As you can see, endometrial atrophy causes most of the cases of postmenopausal bleeding. However, note na pwede rin siyang due to endometrial cancer. That is why, kahit most likely endometrial atrophy ang cause ng postmenopausal bleeding, kailangan pa rin natin silang i-work up at i-investigate, okay? To rule out if there is any underlying pathology, particularly endometrial cancer. So again, bakit kayo nag-bleed with endometrial atrophy? So nagkikis-kis na kasi yung anterior and posterior myometrium mo. So when that happens, it could occasionally cause spotting in patients who are already postmenopausal, okay? Okay, so we'll go to our first index case under postmenopausal bleeding. We have a 65-year-old naligamit. So take note of her OB4, she's naligamit, and she's complaining of postmenopausal bleeding. Has vaginal ultrasound a thickened endometrium of 7 millimeters. What is your next step of management? So bakit nasabing thickened to 7 millimeters? Ano po ba ang thickened doktora sa age group na yan? So 4 millimeters or less is indicative of low risk of malignancy. Therefore, greater than 4 millimeters in the postmenopausal age group, that's considered thickened, and it warrants investigation. Okay? So for this patient, we perform endometrial biopsy. So that is the next step in your management. Doktora, pag ganito po ba pwede ko itong i-label na EUB? Kasi po ano, di ba, parang EUBM po to, di ba? Kung yun po yung nirule out nyo, yung mga malignancy, hyperplasia, no. Kapag postmenopausal na yung patient, hindi mo na yan i-label as abnormal uterine bleeding. We reserve the abnormal uterine bleeding until siguro sa mga perimenopause. Pero pag postmenopausal na sila, we have a special denotation for them, no? We call them postmenopausal bleeding instead of labeling them as abnormal uterine bleeding. Okay? Malinaw? So kapag 65 years old yun, hindi na silang i-label na EUB. Okay? Postmenopausal bleeding na yung ilalagay nyo sa assessment and sa history taking nyo. Alright, so okay, performed endometrial biopsy, and this was the result, okay? Endometrial adenocarcinoma, endometrioid type, FIGO grade 1. So yun yung full na histologic diagnosis, no? Yung endometrial pathology. Okay, so this patient is a case of endometrial cancer. So itong patient pa natin, meron siyang risk factor for endometrial cancer. We'll see. Okay. So, ang main theme ng risk factors mo under the post-endometrial cancer is unopposed estrogen stimulation of the endometrium. So, kailan ito nangyayari? For example, nag-menopause ka after 52 years old. So, ibig sabihin, incessantly, nag-regla ka lang, so incessantly na-expose ka to estrogen, then you have a higher risk for developing endometrial cancer. Okay? Before sa local guidelines natin, kapag you're still regularly menstruating by the age of 52, that already warrants endometrial biopsy. So, ngayon, wala naman yung guidelines na yung regularly menstruating at 52 do endometrial biopsy. Pero still, if greater than 45 years old ka and you're presenting with abnormal bleeding, ayan, binabiopsy namin yan to rule out an underlying endometrial pathology, particularly endometrial cancer. So obesity, how can obesity cause endometrial cancer? No? So your fat cells kasi it contains aromatase, which converts your androgens to your estrogens. So mataas yung circulating estrogens in these patients, and this causes estrogen segregation to your endometrium. So ano pa yung isang risk factor which is present in our patient? No? She is nulliparous. So what happens kasi when you're nulliparous is continuously ka lang nag-regular, continuously ka nag-undergo ng ovulatory cycles mo, di ba? So when that happens, wala kang periods of time na kagaya ng sa mga buntis na hindi sila exposed to high estrogen levels. Okay? Naget niyo yun? So since never silang nabuntis, wala silang break from estrogen stimulation during their cycle. So sila yung mas likely na mag-develop ng endometrial cancer. I hope that's clear. So these are just some of the risk factors for your endometrial cancer. So ano naman yung mga protective mo? So syempre, if menopause at a later age, menopause at an earlier age will be protective for endometrial cancer. Multiparity, bilang multiparity is a risk factor. I already explained why this is protective. Itong use of OCT, this is protective against endometrial cancer kasi na-maintain niya yung thinned out endometrium. No? So hindi siya kumakapal, never siyang nagkakaroon ng chance maging hyperplastic, which would eventually become carcinomatous in the future, okay? So, or cancerous in the future. So, yun yung role ng progestin in your combined oral contraceptive pills in terms of being protective against endometrial cancer. So, I have a question. Ito ay, ano yung ironic na risk factor? Na protective against endometrial cancer. So, itong factor na to is also protective against preeclampsia, okay? So, ironically, yung smoking history that is protective against endometrial carcinoma. So, sabi nila yung mga smokers, ang sinasabi nilang pathophysio or pathogenesis behind it is hindi kasi maganda yung endometrium ng mga smokers no, because of the hypoxia. So, hindi siya nagpo-proliferate. Therefore, hindi sila nag-develop ng endometrial cancer. So, yun yung mga proposed mechanism or protective mechanism ng smoking against endometrial cancer. But still, that doesn't, excuse you from smoking. Marami kang ibang kalaman if you smoke. So, hindi porke protected siya against preeclampsia and endometrial cancer, mag-smoke na kayo. Alright? So, that's interesting lang to note. No? Ironic siya na risk, a protective factor against this type of cancer. Okay. Now, di ba, I mentioned kanina nung sinabi ko yung endometrial biopsy result, meron siyang grade. May SIGO grading na na-mention doon. So, anong ibig sabihin ng SIGO grading? It's graded from grade 1 to 3, from well-differentiated to poorly differentiated. So, grade 1 yung pinaka-gusto mo, grade 3 yung pinaka-ayaw mo. And ang basis natin for this is the percentage or the ratio or the proportion of your solid components. Mas maraming solid components, mas pangit. Okay? So, they say that histologic grade is the most important prognostic factor for endometrial cancer. So, tinatanong din po occasionally sa boards nyo. This came from Blueprint. Okay? So, what are your other prognostic factors? These are your age, depth of myometrial invasion, histologic type, surgical stage, peritoneal cytology, involvement, tumor size, lymphovascular invasion, and pelvic node metastasis. Pero despite all these, ang pinaka-important daw na tinitingnan is kung ano yung histologic grade ng patient. Okay, meron tayong mga kinds ng endometrial cases na either type 1 or type 2. So ano ibig sabihin ng type 1, type 2? Alin yung mas gusto mo? Mas gusto mo si type 1, okay? Si type 1 bakit? So ang prototype na histologic picture niya is endometrioid carcinoma. Si type 2 mas pangit na serous papillary. Okay, mas pangit yung prognosis nito. Yung typical patient mo sa type 1 is yung mukhang nag-undergo ng unopposed estrogen stimulation. Okay, so kumbaga yung binascribe ko kanina na mga risk factors, etc. Ito siya, meron siyang type 1 na endometrial CA. Okay? So yun yung typical picture ng endometrial CA patient. So they're in the peri or early post-menopause, hyperplastic background yung endometrium nila, meaning possibly itong patient na to prior to having endometrial cancer, merong hyperplastic changes na yung kanyang endometrium. Low grade usually, yung kanilang histologic type. And this one is estrogen dependent and the estrogen receptors are positive. So mas gusto natin to. They have better prognosis compared to your type 2. So yung mga type 2 no, ito kasi yung sporadic no. So ibig sabihin meron kang gene mutation, may pangit na mutation kaya ka nagkaroon ng type 2. So very unpredictable yung mga type 2 patients natin compared to your type 1 na alam mo lang na dahil siya sa estrogen dependent or sa unopposed estrogen stimulation. So mas madali namin ito ma-address actually. So ang pangit sa type 2 is they typically come from an atrophic background ng endometrium. So instead of the hyperplastic yung kumakapal na lang yung matres, atrophic yung endometrium na pinanggalingan itong cancer na to. They are usually high grade in terms of histologic type. They're non-estrogen dependent and therefore they have a poorer prognosis. So between the two of them, ang ayaw mo na type ng endometrial cancer is this picture, no? Si type 2 na endom CA. Mas gusto mo si type 1. Now, how do we address endom CA? So anong stage si patient? Ano ba ang staging ng endometrial cancer? Ang endometrial cancer is surgical-pathological stage. Meaning, kailangan mong operahan ng patient at kailangan makita mo yung histopath result bago ka magsabi ng final stage mo. Okay? So sa patient na to, ito lang yung diagnosis ko sa kanya. Endometrial adenocarcinoma, endometrioid type, SIGO grade 1, confined to the corpus. So wala ka akong masabi sa kanya na stage ng patient. Because, pag nagtanong siya, Dr. ano pong stage ko? Pwede ka magsabi ng likely stage siya, pero wala ka pang masasabi at this point kasi kailangan maoperahan mo siya. Kailangan mabuksan mo yung specimen and magkaroon ng exploratory, kailangan ma-explore mo yung peritoneum niya para masabi mo kung ano yung intraoperative stage ni patient. Okay, so ano ba ang treatment, ano ang surgical plan mo for patients with endom CA? Ito ang full na plan mo for the patient. So, same lang tayo ng lymph node dissection sa yung ovarian growth, no? Bilateral lymph node dissection or BLND, plus minus para aortic lymph node sampling. Alright? So, the full surgical plan for this patient is exploratory laparotomy, peritoneal fluid cytology. So, same lang din po ng ovarian growth na malignant, extrafacial hysterectomy with bilateral salpingo-operectomy and your lymph node dissection, plus minus para aortic lymph node sampling. So, para anong difference po ng typical total hysterectomy with extrafacial hysterectomy? This is your uterus, no? And ito yung cervix niyo. This is your vagina, your bladder. And then, ang important na structure dito na manote is your pubocervical fascia. Okay? Pag sinabi mong subtotal hysterectomy, hindi namin sinasama si cervix. Okay? Sa subtotal hysterectomy. Pag sinabi mong total hysterectomy, kasama na nun si cervix. Pag sinabi mong extrafacial hysterectomy, we dissect the pubocervical fascia. Ibig sabihin, pag tinanggal mo yung uterus, dapat kasama mo si pubocervical fascia. Okay? Yun talaga ang distinguishing na characteristic ng extrafacial versus your total hysterectomy. Kailangan kasama si pubocervical fascia mo kapag nag-remove ka ng uterus. Now, I'll orient you na at this point sa mga possibly makita yung structures when you open your uterus, no? Kapag nag-assist kayo sa mga gyne-onco, ganyan, or sa gyne, pag nag-extrafacial hysterectomy sila. So, at this point, gusto ko kayong i-orient sa mga ligaments that are important to us. So, this is your uterus, these are your fallopian tubes, ito yung ovaries nyo. So, ang una namin gagawin usually is to perform ligation of your, hindi kita dito, I'll just draw, ayan, your round ligament. So, your round ligament is below your fallopian tube, pababa to the labia majora. Okay? So, yan yung una namin ilalagate, your round ligament, okay? So again, dito siya sa anterior surface ng uterus mo, below the point where the fallopian tube attaches to your uterus, okay? So yan ang minsan nalalagate on bilateral tubal ligation. Kaya important before kayo mag BTL or bilateral tubal ligation, kailangan mag-visualize yung fibria, okay? Kasi yung iba, nagkakamali sila, yung round ligament, yung nakakagit nila, ito yung nalalagate nila. Okay? So when we perform total hysterectomy, ito yung una namin ilalagate, yung round ligament. So next namin ilalagate is the IP na tinatawag, your infundibulopelvic ligament. So this suspends your adnexa, particularly your ovaries and the surrounding fallopian tube to the posterior abdomen. Okay? So palikod yan, si infundibulopelvic ligament. Ang important sa kanya is, andito galing yung main blood supply mo ng ovaries. So, si ovarian artery nasa loob niyan. So, important na maganda yung ligation mo at this point kasi pwede kang mag-bleed out if hindi maganda yung pagkakatay mo sa infundibulopelvic ligament. So, kung dito, sa view na to, sa sagittal view, andito sa infundibulopelvic ligament. Alright? Okay. So, next na ligament na important to us is your broad ligament. So, nakita mo siya itong fan sheet, no? Na ligament below your adnexa, below your fallopian tube and your ovary. Okay? So, yan, yung fan sheet na yan, that's your broad ligament. And the thickest portion of your broad ligament will make up your cardinal ligament. Pag tinanong kayo ano ang major support ng vagina, ng cervix, ng uterus, it's actually the cardinal ligament. Okay? Ito siya, yung thickened portion below the uterus and surrounding your cervix, no? Si cardinal ligament. What's the other name of your cardinal ligament? Transverse cervical ligament. Kasi as you can see, nasa side siya ng iyong cervix. Meron din siyang proper name, which is your Mackenrod ligament. But most of the time, we just refer to this as your cardinal ligament. Okay? So your other important ligament, which connects your posterior uterus to the sacrum, particularly S2, S3 level, is your uterosacral ligament. So ito yung mga nilalagate namin, no? So important malaman itong mga ligaments, lalo na dun sa mas advanced na hysterectomy, which is your radical hysterectomy. Okay? So yun yung mga important ligaments that you have to know. Pero ang importante in terms of extrafascial hysterectomy, kaya siya extrafascial is because we include the tubocervical fascia in your specimen. Kapag walang tubocervical fascia ang specimen mo, sobrang white nung cervix mo, okay? Cervical part ng specimen mo kasi nakalbong siya. Pero pag meron kang nag-extrafascial hysterectomy ka, kasama siya, no? So hindi siya ganun ka white yung itsura niya sa gross specimen. Alright, so that's your extrafascial hysterectomy for you. Okay, so for example, your patient already underwent extrafascial hysterectomy. So paano mo na-stage yung patient? So na-open mo na yung uterus, nakita mo na rin yung na-assess mo na rin yung lymph nodes intraoperatively. So ganito mo siya sinistage. So isa-isahin natin to guys. Okay, nagtatanong sila ng staging pabord. So yun pa lang, aralin na natin siya. Ito ang pinakamadaling cancer staging, believe me, compared to ovarian versus cervical cancer. So how do you memorize this? I will help you with the mnemonics that I know about this staging. So pag sinabi yung stage 1A, the myometrial invasion of the endocervical, of the endometrial tumor is less than 50%, so less than half. 1B, if the invasion into the myometrium is more than 50%. Stage 2, if the cervical stroma is involved. Remember guys, before kasi, ang stage 2 includes cervical glands, no? So hindi lang dapat glands yung involved sa stage 2. Dapat talagang nandun siya sa meat ng uterus, nasa stroma ng uterus yung tumor mo. So that's stage 2 for your endometrial carcinoma. Stage 3 is beyond the uterus already. So itong stage 1 and 2, nasa uterus pa yan. Yung stage 2 na may cervical stromal involvement lang compared to stage 1. There's a stage 3, beyond the uterus na siya. 3A, if it involves the adnexa or the serosa of your uterus. Stage B, if it involves the parameteria or your vagina, okay? B. Kaya siya stage 3B because vagina. Vagina yung involved or yung parameterium. Your parameterium, remember, if we review your anatomy, it's this one, no? It is lateral to your cervix. Pag stage 3C naman, C stands for kulane. So may lymph node involvement na. C1, if your pelvic lymph nodes are involved. C2, kapag mas mataas na yung involvement niya, nasa para-aortic lymph nodes na. Now, stage 4, just like your other cancers, no? This is already beyond your gyne organ. So beyond already the system that that is primarily involved. So stage 4A, it is the ones that are just beside your pelvic organ, beside your uterus, which are your bladder and or bowel mucosa. Note na dapat bowel mucosa, okay? Ibig sabihin, nasa loob nung bowels yung tumors na. Stage 4B, if you have action. Stage 4B, if you have signs of distant metastasis, including intra-abdominal organs and inguinal lymph nodes. So nasa labas na yung lymphadenopathy mo. Kapa mo na siya sa inguinal lymph nodes mo. Okay? So that's your endometrial cancer staging. So for example, si patient mo, nung binuksan mo yung uterus, you see na meron na siyang less than 50% myometrial invasion. So ano action. So for example, si patient mo, less than half lang ng myometrium yung involved. Or sige, gawin natin, hanggang endometrium lang siya, wala siyang myometrial invasion. So ano na yung stage ni patient mo? Dito na at this point, makaka-commit ka na, no? May intraoperative stage ka na. So endometrial adenocarcinoma, endometrial type, FIGO grade 1, intraoperative stage 1A. Pwede pa po ba yung mag-upgrade, doktora? Pwede pa siyang mag-upstage? Yes, depende sa histopath findings ng patient mo, no? What if kasi grossly, wala ka naman nakikita ng lymph node involvement. Pero yung pala, involved na si para-aortic lymph nodes mo. So ano na yung stage patient? She is at least stage 3, C for kulane, and 2. Kasi diba, C1 is for your pelvic lymph nodes, C2 for your para-aortic. Okay, so example lang yun. So syempre, since ito ay final diagnosis, kailangan isama mo yung procedure na ginawa mo kay patient. Okay? Naget? Alright, so let's move on to another case of postmenopausal bleeding. So we have a 51-year-old G7T77007, so grandmother pa na to, who consulted for foul-smelling vaginal discharge and postmenopausal spotting. Speculum examination showed a home gating necrotic mass. So paano tingnan yung mass na ito? Measured 2 by 2 centimeters at the posterior lip of the cervix. So what should you perform to confirm your diagnosis? So ano muna yung iniisip mo? May siyang foul-smelling discharge, may siyang postmenopausal spotting. This is likely a case of cervical carcinoma. So how will you confirm your diagnosis or your suspicion? You must perform cervical punch biopsy. Ipapap smear mo pa ba to? Hindi na. Remember what is pap smear? It's a secondary form of prevention, meaning hindi pa evident yung disease pero tinatry mo siyang i-catch. Okay? So dapat, kapag meron ka ng evidence of disease, hindi mo na siya ipapap smear. Hindi ka na mag-screen for it. Dapat hanapin mo na yung definitive histopath diagnosis ng patient. So for that, we perform cervical punch biopsy. Okay? So cervical cancer, ano ang necessary cause niya? It's HPV infection or human papilloma virus. Okay? So that's your HPV. So cervical cancer is a sequelae of persistent HPV infection. Typically, typically in an immunocompetent patient na hindi naman repetitively exposed to your HPV or your this virus that is typically transmitted via sexual intercourse or sexual contact, dapat makiklear mo yung HPV infection. Okay? So that's for your immunocompetent, lalo na sa mga young patients, makiklear naman nila yung HPV infection. So, ang HPV is marami siyang types, no? Marami siyang variants. Ang notorious na nakakakos ng cervical cancer are these two, 16 and 18. So sa books, at least 80% of your squamous carcinoma of the cervix are caused by your HPV 16 and 18. This is the reason why yung earlier na HPV vaccines, your quadrivalent vaccines, they address 16 and 18. And may added protection sila na against warts, which are caused by your HPV 6 and 11. Okay? So yung Cervarix, which is bivalent lang, 16 and 18 lang yung ina-address niya. Merong mga newer vaccines na anti-HPV, non-valent na yun, so mas marami na silang high-risk types na ina-address. So, dahil HPV ang necessary cause ng cervical cancer, anything that incessantly exposes you to HPV infection will cause cervical cancer. So, ano yung mga examples na yun? So, these are just some of the risk factors. Hindi ko nababanggitin isa-isa lahat. Kasi important dito, alam nyo yung theme. Ano yung underlying risk factor behind all these risk factors? So, one is high parity. Sa older guidelines, older CTGs ng POGS, ng SGOP, ng Society for Gynae Onco, define niya yung high parity of at least 7. So, si patient natin, di ba, G7, P7 siya. So, ito yung risk factor ni patient. Having multiple sexual partners, so wait, let's go back to that thought. Bakit high parity? Bakit siya risk factor for cervical cancer? So, kapag buntis ka kasi, no, nag-iiba yung immunologic response mo, you become more susceptible to the HPV, to the virus that is HPV. And also, on top of that, nag-i-evert kasi yung cervix mo during pregnancy. So, when that happens, your cervix becomes a good environment for persistent HPV infections, no? So, pwede yung mag-persist and eventually the long-term sequelae of that is cervical cancer. So, another risk factor is having multiple sexual partners or having been exposed to the HPV, to the HPV, virus of HPV, at an early age, at age 14 or earlier, or 2 years from menarche. So, that's considered early coitus. Okay, so again, yung high parity early coitus and yung specific number ng sexual partners defined yan sa earlier editions ng CTG ng SGOP. Okay? So, but essentially, basta alam mo lang na persistent HPV infection, therefore, kapag na-expose ka sa HPV, mas mataas yung risk mo for having cervical cancer. Okay. So, as I mentioned a while ago, dito important yung alam mo yung anatomic structure sa management ng cervical cancer. Ano na ang mainstay mo na treatment for across all stages? So, the mainstay of treatment is chemoradiation actually. So, yung chemoradiation, kaya ka nag-chemo, concomitant with your radiation is gusto mo maging radio-sensitive yung cancer cells mo when you perform radiotherapy. So, yun yung mainstay treatment talaga across all stages yan. However, in earlier stages of of cervical cancer, you may perform surgery in the form of radical hysterectomy. Diba? Kung kanina sa endometrial cancer is extrafacial, pagdating mo kay cervical cancer, yung type of hysterectomy mo is now radical hysterectomy. So, pag sinabi mong radical hysterectomy, kaya siya radical kasi talagang sasagarin mo yung ligament mo. Up to the dulo talaga yan. So, yung cardinal ligament mo, up to the attachment niya, as close to the pelvic wall as possible, dun mo siya i-dissect. Okay? Okay, so ganun. Talagang sasagarin mo siya up to the attachment ng ligament towards the pelvis. So si uterine ganun din. Up to the, as much as possible, as close to the sacrum as possible, ang pagtanggal mo ng radical hysterectomy specimen. Tapos, ang isa pa kay radical hysterectomy, part of the vagina you also remove, no? Sa extrafacial, saka yung typical mo ng hysterectomy, hindi naman kami nag-i-include ng portion ng vagina. But in radical hysterectomy, we include parts of the vagina. Bakit ganun, doktora? Bakit kailangan mo mag-include ng parts ng vagina? At bakit kailangan mo sagarin yung mga ligaments up to their attachment? This is because loco-regional ang spread ng iyong cervical cancer, no? So it spreads via local invasion. So it also spreads via the lymphatics, pero ang primary mode niya ng metastasis to the other organs is through local invasion. So local regional yung kanyang spread. So kaya mas sagad ang pag-dissect mo with radical hysterectomy. Naget? Okay, so we'll now move on. Okay, so ito guys, I'll leave the staging up to you, no? Hindi ko na isa-isahin. May gusto lang akong i-emphasize na certain things about your cervical cancer staging. So note no na, hinighlight ko yung less than or equal to sa 1A1, pati 1B1, less than or equal to yan, pati din sa 2A1. Bakit? Kasi ang nasa printed na CTG na release nung I think 2018, greater than itong 3mm na to, greater than itong 2cm na to. So kinorek na yan recently. So after na print yung CTG, kinorek na siya ng FIGO, no? Yung staging niya. So just take note, alalahanin nyo lang, yung equal to is dapat nandun siya sa lower stage instead of dun sa higher stage. Okay? Kasi yung dun sa mga previous editions ng guidelines, at saka yung mga nakaprint na guidelines kasi greater than or equal to, nakalagay siya sa 2A. So dapat less than or equal to. Nagat yun? So si equal sign, nandun siya dapat sa lower stage. Yun yung ipa-follow. Okay? Even si FIGO, nag-print out din siya, nag-publish din siya online na greater than or equal to nandito sa higher stage. So dapat dun siya sa lower stage. I hope that's clear. Okay? So I'll leave the staging up to you guys. Pati ito kung paano itong 1, different 1, sa 2, sa 3, and sa 4. I'll leave that up to you in the interest of time. So bakit important na nanook correction na yun, no? Kasi diba mag-iiba yung management mo. Because, sino ba yung mga pwede mong i-radical hysterectomy? Okay? So ito yung mga stages na pwede mong i-radical hysterectomy. Si 1A, obviously, because microscopic lang yung diagnosis mo dito ng cervical cancer. So definitely, pwede mo siyang i-radical hysterectomy. Si 1B1 saka si 1B2, pwede mo rin silang i-radical hysterectomy kasi ang greatest diameter or dimension ng iyong tumor is less than or equal to 4 cm. Okay? So yun yung marker nyo lang, pwede kayong magkaroon ng action. Okay, so pag less than or equal to 4 cm, pwede kayong mag-radical hysterectomy. So ano pa yung isang stage na pwede ka mag-radical hysterectomy? Si stage 2, 1A. Kasi less than or equal to 4 cm yung greatest diameter niya. So beyond the stage, hindi ka na pwedeng mag-radical hysterectomy. Okay? So imagine nyo na lang, essentially, lahat ng stage up to stage 2A1, pero isi-skip mo si 1B3. Okay? Kasi meron siyang tumor size na greater than 4 cm. So imagine kung hindi nila na-correct yun ng maayos, no? So makakasama ka pa ng stage 1B3 saka stage 2A2 na i-radical hysterectomy kung dito yung greater than or equal to na sign. Okay? So ang marker mo na pwede ka mag-radical hysterectomy is the greatest tumor size is less than or equal to 4 cm at up to stage 2A1. Alright? Yan. Okay, so one more thing that I want to emphasize regarding the new staging of cervical cancer is we have a new stage 3C. Dati itong stage 3 hanggang stage 3B lang siya, but with the newer staging, may stage 3C na. So bukod doon, meron pa siyang tinatawag na R and P mutation. So ano yung sabihin ng R and P mutation? Before kasi, ang classic question ang classic answer sa tanong na alin ang gynecologic cancer na via clinical staging mo lang sinistage, the answer is cervical cancer. Okay? Purely clinical ang staging ng cervical cancer. Pero ngayon, meron na tayo tinatawag na radiologic and pathologic evidence of metastasis. So, kapag isusulat mo to, meron kang stage 3, C1, tapos maglalagay ka ng subscript, either R or P. Depende kung paano mo na-document yung metastasis. So, the pelvic lymph nodes or the para-aortic lymph nodes. Kapag via imaging or via MRI or CT scan, you see that it's 3C1 with a subscript of R. Okay? Lowercase na R. Kapag via pathology, meaning na biopsy mo itong lymph nodes na to, then you put P instead of R. Okay? Nag-get? So, yun yung bago sa cervical cancer staging. Alright? Ayan. So, ito lang guys, paano nyo ma-distinguish on rectovaginal examination yung parametrial involvement or pelvic wall involvement? Remember guys, diba si stage 2B, meron siyang parametrial involvement pero wala pa daw siyang pelvic wall extension. Ang description nun sa rectovaginal examination ay nodular pa lang siya. Okay? So, 2B ka pa lang pa ganun. Okay? So, ibig sabihin ng nodular, ito makapalpate mo na parang medyo makapal na yung parametria mo, no? So parang yan, nodular siya kasi nandito pa lang yung cervical cancer cells mo, yung cervical cancer tissues mo. However, if it extends to the pelvic wall, like in this picture, no, abot na siya sa pelvic wall, ang description mo na sa parametria mo ay 6. So the moment na i-describe yan ng resident mo or ng fellow mo na bilateral parametria are 6, automatic na yan, you know that there is extension to the pelvic wall. So stage 3B na siya. Nag-get? Okay. So yan, let's now go to the other chief complaint sa postmenopausal patients. So ito yung isa nilang chief complaint aside from postmenopausal bleeding. So they could present to you with prolapsing introital mass. So ano kaya ito, no? Yan. So you have a 60-year-old G8, 8008. Ang chief complaint niya, buwa. Buwa is the Tagalog term for your pelvic organ prolapse. Doktora, meron po akong buwa. So yan, madalas namin yung nalilinig sa outpatient department. So for the history of this patient, ang sinasabi niya sa'yo is she has a prolapsing introital mass which she observes when she's coughing or while carrying her grandchildren. So may increased intra-abdominal pressure. So doon niya mas nanonote na lumalabas yung kanyang buwa. Other than this, she has no associated symptoms except for difficult voiding. Doktora, mahirap pong umihi. Para kung makaihi ako, kailangan ipasok ko muna yung buwa para malabas ko yung ihi ko. So we actually have a special term for this na yung mga urogynea. They call this splinting. So you perform digitation or you reduce the prolapsing mass to be able to void or to defecate without difficulty. Okay, so bakit nagkakaroon ng ganung symptoms? Because kasama sa nagpo-prolapse mo is part of your bladder wall. So this is what you call cystocele. So pwede ko rin may rectocele, yun naman yung counterpart niya. Pag part of your rectum ay nagpo-prolapse with your pelvic organ prolapse. Okay, so hindi lang uterus ang lumalabas kapag meron kang buwa or pelvic organ prolapse, it's also your surrounding organs. Alright, so ano ba ang number one risk factor mo for developing pelvic organ prolapse? It's vaginal childbirth. Okay, so this increases the risk up to 10 times. No, single childbirth pa lang yun, vaginal childbirth. So this patient naka-8 daw siya. So granulipara ito si mother. So more 80 times ang kanyang risk for developing pelvic organ prolapse. So these are the other risk factors and associations with pelvic organ prolapse. So bakit matagal naman nang nabuntis to si mother, matagal naman yung childbirth niya. In between naman hindi naman lumalabas or nagmamanifest yung pelvic organ prolapse. Bakit ngayon na lang na 60 years old siya? This is because the patient is already postmenopausal. So mababa na yung estrogen mother. So because of that, weaken na rin yung connective tissues in your suspensory ligament. So because of that, nagmamanifest na yung pelvic organ prolapse in this stage 2. So how do you treat pelvic organ prolapse? You can do expectant management, no? Pag hindi naman worrisome for the patient, yung pelvic organ prolapse, pwede lang siyang i-observe. You can also use pessary. So pessary, it looks like a donut. Most of your pessaries look like that. And then you insert that into your introitus para mapigilan yung pag-prolapse nung uterine, nung pelvic organ mo, particularly your uterus. You may also perform surgery or vaginal, action. You may also perform surgery in the form of vaginal hysterectomy. So yung position niya kapag i-OR mo siya is naka-dorsal position ka, and that's how you remove your pelvic organ prolapse, your uterine prolapse. Okay, so how do we assess patients with pelvic organ prolapse? We have what we call the POP-Q scoring system, which stands for POP quantification. Okay, so we have 6 points measured at the vagina with respect to the hymen. Okay, so ito yung anatomic landmark ng si hymen. Okay, so ito si hymen sa sagittal view. Dito sa view na to, from the dorsal position view, ito si hymen. Okay, so siya yung magmamark ng 0 mo. So, di ba, remember dun sa Libor, kung si 0 is marked by your ischial sign, in POP-Q, ang 0 mo ay si hymen. So, any point above the hymen, ibig sabihin, nasa loob siya ng vagina, dapat negative yung score niya. Anything below the hymen, may nasa labas na siya ng hymen, nasa labas na ng introitus, dapat positive number yung kanyang score. Malinaw? So, there are 6 points na measured at the vagina are your anterior wall, A, B, A, C, A, P, B, P, and D. So, isa-isahin ko yan sa inyo para maintindihan nyo. No? So, gusto ko lang na maintindihan nyo siya at this point. So, mamaya nyo na i-memorize later on pag nag-rotate na kayo sa OB. So, aside from these 6 points na to, na later on ko na i-discuss in full detail, you should note that there are 3 additional values that we write in the POP-Q score. So, meron tayong 3x3 matrix. So, si genital hiatus or si GH. Ano ibig sabihin ng GH? GH is yung measurement mo between the external urethral orifice to this one, no? To the posterior na midline hymenal area. Okay? So, yan si GH. So, ito siya. Yan si GH. Okay? So, when you say perineal body, a perineal body is itong dulo ni GH up to the anal opening. So, that is your perineal body. So, this should be PB instead of PH. Okay? Perineal body to. When you say total vaginal length, it means na i-reduce mo, ipapasok mo yung nagpo-prolapse na mass, and then you get the total vaginal length. So, ganyan mo i-measure si total vaginal length. Ano ang special kay total vaginal length? So, lahat ng to, yung itong first row and itong third row, pati itong genital hiatus sa perineal body, dapat yan, nagbabalsalva, full valsalva yung patient. Papailihin mo siya habang i-measure mo. Except for total vaginal length, wherein kailangan naka-relax si patient at ipapasok mo or i-reduce mo yung prolapsing mass. Nag-get? Now, we'll move on to the more difficult parts of your POP-Q scoring, which is the 6 points. Itong first row sa itong third row. Okay? So, ano bang ibig sabihin ni AA? Si AA is 3 centimeters from the hymen sa anterior wall mo. So, ibig sabihin nito, ang values niya ay pwede lang from -3 to +3. Hindi ka pwedeng mag-4, okay? Hindi pwedeng +4, okay? Take yung pop score mo pag yun yung nilagay mo sa anterior wall. So, siya ay kumbaga arbitrary point na measure from the hymen to that of the anterior wall. So, ito si AA. Kung ito yung vagina mo, ito si AA kapag nasa normal position siya. So, nasa -3 siya dapat. Okay? So, ang counterpart niya sa posterior wall mo is si AP. Okay? So, sa posterior wall mo, from the posterior hymen, centimeters from it, yun si AP. So, gaya ni AA, dapat si AP ay -3 to +3 lang yung value. Okay? Nag-get? So, -3 to +3 lang. Alright? So, ano naman si BA? Si BA, siya yung most prolapsed portion ng anterior wall. Okay? So, kung sa normal position mo ng pelvic organ, si BA dapat nandito siya sa loob. Dapat negative yung value niya. Okay? So, kapag lumabas yan, yung most prolapsed anterior portion, yun si BA. Si posterior wall, BP naman, siya yung most prolapsed portion ng posterior wall. Okay? Tapos si C, siya si cervix. Okay? Ito si cervix. Si posterior fornix, iba pa siya. Ito si posterior fornix. Nag-get? So, ito si cervix, ito si posterior fornix. Sa drawing na to, ito si posterior fornix, ito si cervix. Okay? So, lahat ng negative values, yung anterior wall, yung AA, yung BA, yung cervix, yung AP, yung BP, yung B, lahat yan negative values dito sa picture na to. So, paano nyo siya madaling maintindihan? Essentially, kapag halimbawa gagawin mong ililipat mo itong drawing na to, no? So, si A, si B, si C, si D, si P, si A, para siyang yung matrix ng POP. Ito si A, ito si B, ito si C, D, B, P. Nag-get nyo? No? So, para siyang, kung i-drawing mo siya, ito yung cavity mo, vaginal cavity mo. Ganyan mo siya i-imagine. So that, halimbawa, pag meron kang prolapse, kan ulit tayo. Diba, andito si A, tapos andito yung A mo originally, nasa -3. Pag halimbawa, nag-prolapse siya of the hymen na si A mo. So, yan ay 0. So, halimbawa, yung most prolapsed anterior mo. So, from here, ito dapat yung anterior wall mo, lumabas siya dito. Tapos, si C mo, lumabas din siya dito. And then, si posterior fornix mo is somewhere here. Si posterior wall mo, na most prolapsed is somewhere here. Ayan. Tapos, si posterior wall na 3 centimeters from the hymen is somewhere here. Ayan. So, ganun mo siya i-measure. Nag-gets nyo ba? So, essentially, parang kung drawingan mo itong pop score mo, para talaga siyang essentially drawing ng loob, yung sagittal view ng iyong pelvic organ. So, ganun mo siya maaalala. Okay? So, ganun din siya naituro sa amin. So, para siyang cross-section of a patient in terms of sagittal view. Okay? So, kung hatiin mo pag dito yung patient, ganito mo makikita si pop Q. Para mas lalo nyo matandaan kung ano yung components ng 3x3 matrix ni pop Q. Okay? Nag-get? Okay, so in terms of staging, para madali nyo siyang maalala, ang tatandaan nyo lang si stage 2. Bakit si stage 2? Si stage 2 ay si -1 to +1. So, madali mo siyang maalala kasi i-adjust mo na lang siya. Depende doon. So, less than, pag natataas siya ng -1, yung leading point, ay nasa stage 1 siya. So, isa nyo pang tatandaan is si TVL -2 or total vaginal length -2. So, sa stage 4, which is the last stage in your pop Q staging, kapag ang leading point mo is more than your length sa vaginal length -2 centimeters, or otherwise meron ka ng tinatawag na complete eversion, it means nasa stage 4 ka na. Okay? Bigyan tayo ng example para mas ma-realize nyo siya. O, for example, ganito. So, ang titingnan mo dito, titingnan mo kung meron kang point beyond +1. Kasi yun si stage 2. So, yes, meron, di ba? So, titingnan mo na next kung stage 3 or 4 siya. So, ang next mong titingnan is si TVL, which is this one. So, 8 -2 is 6. So, yung mga leading points ay less than 6 pa. So, ito ay pop Q. Yung pop niya ay stage 3 pa lang. Nag-get? So, another example. Okay, so ito naman. So, tingnan mo, yung first row and second row, ang makikita nyo, ang leading point niya is nasa hanggang +1 lang. So, from -1 to +1, pag andun yung leading point mo, it means nasa 2 lang. Okay? So, for example lang, nasa, ano ka na, for example, kung most prolapsed na anterior portion ay nasa +7. So, since more than siya ng TVL -2, which is 6, then stage 4 ka na. Okay? So, paano naman guys kapag halimbawa na may history yung patient na total hysterectomy siya? Ayan, buburin ko na yung uterus. Ayan, tanggalin na natin yung uterus. So, paano kung na total hysterectomy ka na? Paano mo na isusulat yung pop Q mo? Alin yung mawawala sa scoring system mo? So, kapag na-hysterectomy ka na, pwede ka pa rin ba mag-pelvic organ prolapse? Of course. Remember, ang pelvic organ prolapse is pelvic organ, hindi lang yung uterus mo. So, pwede ka pa rin mag-cystocele and mag-rectocele. So, kapag gano'n lang, ang mawawala sa pop Q score mo is this one. No? Mawawala na si posterior fornix mo. So, ang magkakaroon ka na lang is itong letter C. No? So, instead of the cervix, ang iyong i-note dito is yung length or yung level of prolapse ng iyong vaginal cuff. Vaginal cuff, ito yung, di ba, kapag na-hysterectomy ka na, ganito na lang siya, di ba? Ito na lang yung matitira sa vagina mo. So, ito yung vaginal cuff. So, kung gano'n ka prolapse yan, yun yung ilalagay mo dito sa C. Okay? Tapos wala na itong letter D, wala na siyang posterior fornix. Okay? Arbitrate mo na kasi yan from the previous hysterectomy. Okay, so again guys, ito na yung mga natakal natin. Congratulations for finishing Genesis Gynecology. Ito yung mga topics or chief complaints na natakal natin through our gynecology lecture. So that ends my lecture for now. So congratulations for finishing this very long lecture on obstetrics and gynecology. I hope marami kayong mabaon na knowledge through this lecture. No? Gaya nga nang nasabi ko sa inyo during the first kayo mag-OB gynae in the future, I hope ma-appreciate nyo yung concept man lang or yung principles of management behind our specialty. Kasi kahit hindi kayo mag-OB in the future or kahit hate nyo pa yung OB, for sure, meron kayong mother, meron kayong sister, girlfriend, friend na girl, or nililigawan na nangangailangan ng OBGYN expertise nyo in the future. So that's it for now. See you in the next lecture.